Hello everyone, my name is Nathan Zahar. I'm one of the residents at the Detroit Medical Center downtown campus. So I'm going to present a case today of a COVID patient who came to the emergency department with an ST elevation MI, whose hospital course was complicated by a restenosis of the culprit vessel immediately after the percutaneous intervention. So due to time limitation, I'm going to just dive right into the case. So our patient was a 51-year-old male. He came to the ED complaining of squeezing chest pain and shortness of breath. The patient had a past medical history of a previous MI with a drug-eluting stent placed in the LAD, hypertension, diabetes, and coronary artery disease. His medication regimen included ticagrelor, carvedilol, atorvastatin, and aspirin. So in the ED, the patient's blood pressure was elevated at 165/112. He was rapidly desaturating and was subsequently placed on a 15-liter non-rebreather mask. Also on physical exam, there were crackles heard in the lungs. The patient was severely anxious and had an increased work of breathing. So the differential diagnosis at that time was acute coronary syndrome, acute myocarditis, coronary vasospasm, and coronary artery dissection. So a chest x-ray was obtained. It showed pulmonary vascular congestion. The initial EKG revealed ST elevations in leads 3, AVF, V5, and V6, as well as some reciprocal depressions in lead AVL, as you can see in figure 1 here. So a bedside echo was obtained right after, and it showed an ejection fraction of less than 40%. A troponin was drawn and came back at 175. So at that time, ACS protocol was initiated. The patient had a COVID swab and was rushed straight to the cath lab. Back then, we didn't have the in-house testing for COVID, so the result did take 3 to 4 days to come back. So prior to the cath, the patient received a bolus of heparin, which was dosed according to the ACC, American College of Cardiology guidelines. His activated clotting time, or ACT, was checked and came back at 300 seconds, which is therapeutic. Just as a side note, activated clotting time is similar to PTT. It's just a metric that we use at the Sinai Grace DMC campus. So the initial angiogram showed 100% occlusion of the left circumflex artery, as you can see in figure 2A. A drug-eluting stent was placed in this culprit vessel, and there was complete restoration of flow, as you can see in figure 2B here. However, after the guide wire was removed, the final angiogram showed 100% acute rethrombosis of the same vessel, and that's demonstrated in figure C, figure 2C here. So the ACT was immediately checked again. This was around a half an hour after the initial, and it came back at 167 seconds. So it rapidly dropped to almost half of what it was 30 minutes prior, which is extremely unusual. So the patient was given an additional bolus of heparin. The same vessel was angioplastied, but despite these efforts, his condition continued to deteriorate and ACLS protocol was initiated. Unfortunately, it was unsuccessful and the patient ended up dying of sudden cardiac arrest. So this was a very unfortunate case, and it should really urge institutions as well as independent researchers to produce larger studies pertaining specifically to COVID and heparin resistance, and really just determine if it's necessary to possibly change the current guidelines of anticoagulation therapy during the pandemic for patients who test COVID positive. Not only with ACS, but also with DVTs, pulmonary embolisms, and other manifestations of hypercoagulability. Thank you all for your time. I hope you enjoyed the presentation, and take care.